I hope I am audible and visible to everyone. So, good evening, one and all. So, today we are going to have a short presentation on some toxicology. So, we are presenting after a long gap. And as I said last time, we are trying to do this a bit more often. So, at least we'll try to do this once per week. So, we are starting once again with a case scenario. A 38-year-old lady, she's coming in the middle of the night with complaints of vomiting and dizziness, generalized weakness, some pretty vague complaints. So as always, as with any patient who comes to the emergency department, we'll do a primary survey. And when the primary survey is basically significant for her she's breathing a bit fast, she needs some more oxygen by face mask. She's bradycardic and hypotensive. So her pulse rate of 47 and BPH is 70 by 40. CRT is raised. She is a little bit drowsy. RBC is 75 and temperature is normal. And as you're starting with the situation, so we get history from her relatives that she might have taken some pills from her father's heart medications. So, okay, I don't think I know any one of you, but can anyone suggest two or three differentials for this presentation? Anybody can unmute themselves and say one or two things, or put it in the chat box.
Might have taken a beta blocker overdose.
Yes, so you can have toxicological causes like so beta blockers, calcium channel blockers, anything else that can also cause this bradycardia and hypotension. Toxicological. Okay, we'll come to that. So basically, this whole talk today is going to be on beta blocker and calcium channel blocker toxicity. So we'll start with beta blockers. Both of these conditions are going to be very similar. There's not a lot of differences between these two, and we are presenting with an unknown ingestion. It's going to be almost impossible to differentiate both of these overdoses. Coming to beta blockers, the first thing you have to know is understand how the beta agonists work through the beta receptors. So basically, if you look at the top here, you have their beta 1 receptors in the heart, and the beta agonist comes and combines with this, and these are G coupled protein receptors. So through GS, it will stimulate adenyl cyclase, leading to conversion of ATP into cyclic AMP. And this will ultimately uh, lead to the production of activated protein kinase A, and this will help it to increase calcium inside of the cell. And more calcium inside of the cell will stimulate the release of more calcium from the sarcoplasmic reticulum, that is the calcium-induced calcium release. And this will ultimately help in the contraction of the muscle. So basically, this is how the whole things work. So we have beta, beta receptors on one side, and we also have the calcium receptors. And in the myocyte, the cardiac myocyte, we have your L type calcium receptors. So these are the big players, and you can see that both of them are somewhat interlinked with each other. Coming to the beta receptors in particular, you have beta 1, beta 2, and beta 3. The big ones are obviously beta 1 and beta 2. Beta 1 in the heart, it will increase your inotropy and chronotropy, so that it will increase your contractility as well as your heart rate. And obviously, the beta blocker will have the opposite effect. In beta 2 receptors will have bronchodilation. The big ones are bronchodilation as well as peripheral vasodilation. And it also has some influence on metabolism by stimulating gluconeogenesis and glycogenolysis. So it will help to increase the blood sugar levels. And those are the big things. And so you have beta 1 selective beta blockers. So those are cardiac selective. Those are technically not supposed to have the effects like problems like bronchospasm, etc. But when you have massive overdoses of beta blockers, then this selectivity thing that goes out of the window basically. So then you can have beta 2 blocking effects as well. Coming to beta blockers, I'm not going to go into great detail about the classification pharmacology and all because a lot of the beta blockers are not actually clinically used that commonly. There are some lipid soluble beta blockers, and the thing about these things is that they can readily cross the blood-brain barrier, and in overdose can lead to CNS effects like altersensorium, coma, as well as seizures. So one example is propranolol. Some of these things do have ability to inhibit the sodium channels in the myocardium that will lead to decreased cardiac conductility in overdoses, similar to what you see in tricyclic antidepressant overdoses. And coming to the clinical features, so usually the onset is going to be in somewhere between 1 to 4 hours with your immediate release tablets. If you have some kind of sustained release tablets, then it might be the onset delayed more than 6 hours or so. So the hallmarks that I would want everyone to remember is a combination of bradycardia and hypotension. And you may have QRS widening as well if you have beta blocker with some kind of sodium channel blocking property as well. Hypoglycemia is the only differentiating factor, only clinically practical differentiating factor between beta blocker toxicity and calcium channel blocker toxicity. So in the calcium channel blocker toxicity, you will have hyperglycemia, whereas in beta blocker toxicity, you have hypoglycemia. So the significance here is that if you have the patient with beta blocker toxicity is having hypoglycemia, then that is a poor prognostic marker. Then CNS effects, as I told you, with lipid soluble ones, and you can have bronchospasm as well in overdoses. So CNS and cardiovascular manifestation we have gone through, pulmonary manifestation we have gone through. Electrolytes we look for hypoglycemia as well as hyperkalemia. So in hyperkalemia, one of the treatment that we give is salbutamol. So beta agonists are used in hyperkalemia. So beta blocker overdose can lead to hyperkalemia. So that is another thing that we should watch out for. So coming to the investigation, what are the main investigations? We have to understand that the diagnosis is basically clinical. So there's not a magical test that you're going to do is to help you decide whether this is a beta blocker overdose or not. And so unfortunately, that is how most of toxicology works actually. So the main basic investigation and the normal investigation that we do in almost every patient that comes to the ED in a mostly problematic state, that is the random blood sugar and SpO2 and blood gas. So that will give an overall picture of how the sick the patient is. So drug levels, they don't have much of parole. Drug levels do not correlate with toxicity, and they are not readily available also. Urine toxicology, again, urine toxicology, as I said in the initial lectures on toxicology, they are generally very, very useless. So you wouldn't really bother much about them. And you can get false positive amphetamine results actually, even with things like labetalol overdose. And of course, in each and every one of these patients is obviously going to get an ECG. So any kind of sick patient with bradycardia, so you're obviously going to get an ECG. That's a no-brainer. And obviously, the patient is hypotensive. One of the core pieces of our management is going to be doing a focus to assess the volume status of the patient and how the heart is doing, etc. So coming to the differential diagnosis, so like people said, one of the differential diagnoses is calcium channel blockers. So and the only real practical differentiating feature from beta blocker overdoses is the hyperglycemia. Then you can have other AV nodal blockers like digoxin, which can have again it will be difficult to differentiate. So you will have need a good history as well. So the digoxin will be a close differential. Some naturally occurring substances like oleander can also do. That will basically behave similarly to a digoxin overdose. Okay? So clonidine can be similar, and organophosphates. And organophosphates, what is the big difference? So there also you can have things like bradycardia, but you will also have your basic cholinergic toxidol. So you'll have your all of these secretions in the body will be increased, basically, like salivation, bronchoria, vomiting, diarrhea, etc., urination, everything will be increased in the cholinergic toxidol. So that is one clue that to differentiate this from that. Now coming on to the general management. So this is very, very important. So initially you're going to have to the basic management that we do for any sick toxicological patient. And as we discussed in the initial lecture, the most important part about the management of any poison patient is good supportive care. Without good supportive care, you're not going to save any patient. So if the patient's airway is threatened, patient is having altered sensorium, their mouth is full of, the patient is having a threatened airway or something, or the patient is vomiting and the patient is altered, and you think the patient is at high risk of aspiration, and you want to intubate the patient, then you will have to be very, very careful, because you will have to look. The patient is already going to be bradycardic and hypotension, so there is a very high risk of peri-intubation cardiac arrest. We have to take steps to actually prevent that from happening. So the basic funda is resuscitate before you intubate. So we have to optimize the hemodynamics as far as possible. Start an inotrope and give some push dose adrenaline, and try to optimize the patient's hemodynamics as far as possible before you intubate, and adjust your dosing of your sedative and palliative drugs accordingly to the physiology of the patient. The other things, circulation, obviously, if the patient is hypotensive, initially we'll start with some IV fluids. Generally, IV fluids are not going to be the thing that is going to completely turn around the hypotension for this patient, because it's not going to be purely a fluid depletion kind of problem, like a patient coming with acute gastroenteritis. So this is not going to be a similar situation. So generally, the patient is actually going to be hypotensive. After giving some fluid, generally you will have to start with some kind of inotrope as well. Coming to GI decontamination, this is similar to the general principle that we discussed a few months ago. Basically, if patient is coming very, very early, within 1 hour, then you can consider activated charcoal. Gastric lavage is generally not indicated as per internally, because of high risk of vomiting in these patients, and generally it probably the risks will outweigh the benefits in most of these cases. Whole bowel irrigation can be considered if the patient is coming with a very large ingestion of extended release preparations of the beta blockers. Coming to hypotensive management, as I said earlier, initially you can start with the fluids. Simultaneously, you look at the other things that you can do. If the QRS is wide, more than three small squares wide, then you can give sodium bicarb. That is a general principle in any toxicological case. If you're not sure about what is going on, QRS is wide, if you give some soda bicarb. If the patient have a decreased contractility and on the focus and all, then you can consider all of these interventions like glucagon, high dose insulin, and calcium and adrenergic agents. Similarly, for bradycardia, you can consider things like glucagon, adrenergic agents, and pacing, etc. So coming to glucagon. So if you want to understand why glucagon is significant here, if you go back to this picture and you see that beta agonist acts through the beta 1 receptor, then the GF, then it will stimulate the adenocytes. Whereas the glucagon will go and directly stimulate your adenocytes. So it basically bypasses the beta blocker. That is why it is useful in these beta blocker overdoses. So glucagon, it usually it has a very short onset and duration of action. Onset is between 1 or 2 minutes, and duration of action is around 10 to 15 minutes. And you can repeat a bolus after 15 minutes. And because of the very short duration of action, you might have to actually consider starting an infusion. So generally, the bolus dosing is around 3 to 10 milligrams IV, and infusion of 1 to 5 milligrams per hour. The problem with glucagon is vomiting. So if you are giving glucagon to the patient, be prepared that the patient is going to start vomiting. So that is a very notorious side effect of glucagon that you have to keep in mind. So if the patient is having a dicey airway, then glucagon is probably not a good idea, at least not before you actually intubate the patient. Similarly, they can have problem with tachyphylaxis. So the effect of glucagon will actually decrease with time. The longer you actually continue the infusion. And the most important therapy for both beta blocker as well as calcium channel blocker overdose is going to be high dose insulin therapy. Now, this is one of the great questions: is why does high dose insulin therapy actually work in beta blocker and calcium channel blocker toxicity? So how it works is basically it will facilitate the myocardial utilization of glucose. So basically, when the heart is in a normal state, in a non-stressful environment, heart likes to use free fatty acids for metabolism, for energy, basically. But when a patient is having severe shock and all, then the heart would like to have glucose. And the problem with things like beta blocker overdose is that the patient there will not be a huge amount of glucose available for the heart to actually contact properly. So by giving a large amount of insulin, it will actually increase the utilization of glucose into the cells, and it will improve the cardiac contractility. And the onset is actually pretty quick, and you can see the effect within about 15 to 45 minutes. But it might need to be continued for a long time, maybe even one or 2 days before the patient is actually stable enough to actually start withdrawing this therapy. So the big question is, how do you actually give a high dose insulin therapy? So first of all, before you start giving something like this, you have to check two things. One is your glucose, the one is the potassium. So glucose, if the glucose is less than 200, obviously you'll have to give D50 before you actually consider giving the high dose insulin. And second thing that you have to understand about high dose insulin therapy is that you are giving much higher doses than you would normally give for something like DK or HHS or something. So you are giving at bolus of one unit per kg. So that you can imagine how big that can be. And then you will again start an infusion at the same 1 unit per kg per hour. Now, basically, along with the infusion, you'll have to give dextrose containing fluids as well. Indirectly, here mentions that you give 10% dextrose at around 200 ml per hour for adults. But if you're not having a 10% dextrose solution, we will give something else like a D50 um, infusion as well. You can consider something like that as well. If the patient is unable to tolerate a large amount of fluids, you can consider something like that. Then, what is the goal of the therapy? Basically, hemodynamic goal is to keep the heart rate more than 50 and a systolic blood pressure of more than 100. And the goal with the glucose is to keep it somewhere between 100 and 200. And to actually monitor the glucose around every 15 to 20 minutes. And once it actually settles down to a constant rate, then you can maybe reduce it to around hourly glucose monitoring. Also have to keep a close eye on the potassium and keep the potassium somewhere between around 3, basically 2.8 to 3.2. Adrenaline agonist, again, you can have things like ADR, NORAD, etc. And this is maybe one of the situations where ADR is probably a better option than NORAD, because ADR will give that extra heart rate increasing effect compared to the other agents here. IV lipid emulsion is probably the last line therapy for these overdose beta blocker and calcium channel blocker. And most in animal models are mostly shown to benefit from lipophilic beta blocker overdoses like uh, prop, uh, propranolol and propranolol and carvedilol. And the dosing is basically the same dosing that you will use for local anesthetic systemic toxicity. But given that there is literally very low to almost zero evidence to support this its use in this condition, so it's basically used for when it's refractory to everything else. So basically, the patient is having bradycardia, patient is unstable, patient is having hypotension. So should we consider something like pacing? So transcutaneous or continuous pacing. What about that? The problem is that this is not really a problem with the conductor system. This is more a problem with the myocardium. So oftentimes the patients may be refractory to pacing also. And pacing has its own problem. So transvenous pacing that will lead to a loss of the atrial kick, and it will lead to some sort of uncoordinated contraction of the heart. Ultimately, this might actually be counterproductive because it will, while it can increase your heart rate, might actually lead to a situation where your contractility actually is getting worse. So pacing, the net benefit of the pacing is actually probably not that much, considering, especially considering how invasive it must be. And obviously, transcutaneous pacing is probably going to be even less beneficial in this scenario. Other things, atropine very unlikely to benefit. You can try it, but it's probably unlikely to benefit, and you don't actually wait for atropine to have effect in these conditions. You have to try other things as well. You can add things like calcium, even in beta blocker overdose. It has more of a role in CCB overdose, but you can consider it here as well. Phosphodiester inhibitors, they help to prevent the breakdown of cyclic A and B, but it doesn't really have much of advantage over something like glucagon. Sodium bicarbonate is hemolysis is prolonged, okay, and hemodialysis not much benefit in most cases, except for the few medications that are actually cleared renally. And things like ECMO and VA ECMO and IABP, those things can be considered at an ICU level, not now, but really a thing that we will be starting in the emergency department. So by final disposition, obviously the patient is very sick, the altered hemodynamic and stable, the patient is going to be requiring ICU level of care. What about the other end of the spectrum where patients are not that sick? The patient is asymptomatic with normal vital signs after 6 hours, and the patient has taken immediate release tablets. Then the patient can be discharged after a good psychiatric review after about 6 hours of observation. So that is basically about beta blocker overdose. If anybody has any doubt, they can ask me now. Otherwise, we'll be continuing on to calcium channel blocker overdose. Okay. If there is any issue with the lecture, you can type it in the chat box, and or you can stop me in between us. Okay. So carrying on. Calcium channel blocker basically it will combine with your L-type calcium channel, which we spoke about earlier, specifically the alpha 1 subunit of the L-type calcium channels. And that will basically the L-type calcium channels are basically at three important locations. One is the heart, second is the vasculature, the smooth muscle of the blood vessels, and third is the islet cells of the pancreas. So these are the three big effects that I would like to make you aware of. So you can have effects on the heart, you can have effects on the blood vessels, and you can have effects on the pancreas, and specifically insulin secretion. So in the heart, it will if you have things like verapamil and lithium, will lead to bradycardia and hypertension. And if you have in the blood vessels, if you have overdose of other calcium channel blockers, you can have hypotension with some reflex tachycardia also. And with by inhibiting insulin release, and it has some effect on insulin resistance also, it will lead to hyperglycemia. So that is a big difference between calcium channel blocker and beta blocker. And verapamil is the most potent negative inotrope of all these calcium channel blockers. And in overdose, it causes more deaths than any of the other calcium channel blockers combined. So that is something that you have to keep in mind. And children are particularly sensitive to calcium channel blocker overdose, and even a single tablet in accidental ingestion in children can lead to death. So you have to take those situations very, very seriously. So basically, we have a broad classification of CCBs are dihydropyridines and non-dihydropyridines. Non-dihydropyridines are the big ones that have effect on the heart, that are diltiazem and verapamil. The dihydropyridines are the medication that we usually use for blood pressure, like amlodipine, nicardipine, nifedipine, etc., etc. So the non-hydropyridines act more on the heart, whereas the dihydropyridines will act more on the blood vessels. But as I said with the beta blockers also, once you go into overdose and toxicokinetics, the selectivity for the heart or the blood vessel will go, and you will have effects on at both levels. So So the selectivity for the heart and the blood vessel for both of these classes will disappear at a very high dose. So it can affect both. So coming to clinical features, the immediate release tablets usually have very rapid onset within 1 to 2 hours. Whereas the extended release preparations, we can have much more delayed presentation, maybe even up to 16 hours or so. So this is why whenever you are taking history in any toxicological case, take a look at the tablet or the cover and try to see what kind of tablet it is. It's not just a name. You also have to find out whether it is an immediate release tablet or an extended release tablet because it will have a significant effect on your further management. So most common abnormality that you will see in overdose is going to be hypotension. So with the non-dihydropyridines, you'll have bradycardia with hypotension similar to the beta blockers. In dihydropyridine overdoses, even mild to moderate cases, you will have hypotension, but you'll have reflex tachycardia with the things like amlodipine, etc. So dihydropyridine will lose this sensitivity in large overdose, as I said, and even they can present with bradycardia at very high doses. Respiratory and CNS effects of CCB overdose generally is going to be secondary to decreased cardiac output. So basically, you can have pulmonary edema, mostly cardiogenic, but sometimes non-cardiogenic pulmonary edema has also been recognized with CCB overdoses. CNS effects like seizures, coma, stroke, mostly secondary to decreased cardiac output. GI effects most commonly are going to be nausea and vomiting. If you have large injection of extended release formulation, it can lead to intestinal disorder formation. It can later on lead to obstruction. And the life-threatening bowel ischemia and necrosis can occur even without hypotension with CCB overdose. That's another peculiar thing that you have to keep at the back of your mind. Diagnosis, basically the big differences between this thing and beta blocker overdose is basically the glucose. Glucose they can get hyperglycemia. You can have somewhat around a 70% increase from your baseline blood sugar values. So perhaps it will be around 250, 300, 350, that kind of range. And you can have lactic acidosis slightly more than you will get with the beta blocker overdoses, and hypokalemia basically can be seen in a severe overdose compared with hyperkalemia with beta blocker overdose. And if you have hyperglycemia with CCB overdose, that is again a poor prognostic indicator, similar to how hypoglycemia was a poor prognostic indicator with beta blocker overdose. Now, coming to the DD of bradycardia and hypotension, we already spoke about the toxicological causes. We're adding a couple of other common causes of bradycardia and hypotension. Obviously, ACS is a big cause. Something like inferior volamine obviously can lead to bradycardia and hypotension. Hypothermia can cause hypothyroidism. Decompensated hypothyroidism can cause severe hyperkalemia. Obviously can lead to something like this as well. So coming to the general management of calcium channel blocker overdose is going to be very similar also. So the basic management is the same: SpO2, RBS, ECG, blood gas, etc. All of these things should be given. And coming to GI decontamination, the initial part is most of the things are similar to beta blocker overdoses as well. It's like activity charcoal within 1 hour, whole body irrigation. It's large doses of extended relief tablets. Gastric lavage not recommended. The only extra thing that is coming here is you can try multi-dose activated charcoal if the patient has taken an extended release preparation. You can give multiple doses. So can someone tell me some other indications for multi-dose activated charcoal in toxicology? There are only a handful of them. Other indication for multi-dose activated charcoal, you can type in the chat box or you can say it also. So there's a mnemonic for that. It's called ABCDQ. So aminophyllins, barbiturates, carbamazepine, dapsone, quinine. So all of these things are indications for multi-dose activated charcoal in overdose. So aminophylline, barbiturates, carbamazepine, dapsone, and quinine. So you keep that in mind. So calcium channel blocker toxic overdose. So the therapy is obviously going to involve calcium. So we have two types of calcium preparations. We have calcium chloride as well as calcium gluconate. Calcium chloride is having 13.6 milligrams of calcium per gram, whereas calcium gluconate has about a third of that, 4.5 milligrams per gram of one apple. So calcium chloride probably a bit better option than calcium gluconate because it basically contains more calcium. But the problem with calcium chloride is it is very very prone to causing thrombophlebitis. So you need a central vein to actually give calcium chloride. So if you don't have a central vein in this, you have to go for calcium gluconate, and you'll give triple the dose of calcium chloride basically. So you give 10% and 10 ml of calcium chloride, or over 5 minutes you give triple that amount of calcium gluconate, and you can start an infusion of calcium as well. So basically, you'll have to monitor your calcium levels, and you'll try to go for a slightly calcium threshold of 1.5 to 2 times the normal level. That is what you're aiming for, and you have to monitor your ionized calcium levels every 1 to 2 hours if you're doing that in future. Alternative agents to counteract the hypotension, basically we go for something things like ADR or NORA keeps a map of around above 65. And there have been some case reports about of methylene blue that has been used in calcium channel toxicity as well. So that is something else that you may be considering in refractory cases if you have that available. So high dose insulin therapy, the protocol is basically exactly the same as with beta blocker overdose. The benefit has been seen in some case report. That is why it's basically the big therapy for both of these conditions. Glucagon theoretically shouldn't be that beneficial, but there are some case reports have shown benefit. So you can try a 5 milligram IV bolus of glucagon and see, but again, beware of the vomiting that is inevitably going to come after giving a dose of glucagon. So basically, the approach is going to be very, very similar to the beta blocker overdose. You can just start with some IV fluids, simultaneously give some calcium. And the big thing is going to be your high dose insulin therapy, and you'll you'll be giving uh, something like ADR or NORAD as well. And you plus or minus you might add glucagon as well. So all of these things will generally be started simultaneously. It's not like we are going to be uh, we go step by step. You're mostly going to start almost all of these interventions at the same time. And then the second tier therapies are again lipid emulsion. Generally, the evidence for that in this condition is very, very poor, and other things like ECMO. Then coming to disposition, with immediate release percentage preparations, case will change 6 hours. The patient asymptomatic with normal vitals, get a good psychiatric consult, then you can consider discharging the patient. Extend release preparation, you have to be more careful. You have to give the patient for at least 24 hours before you can consider discharging the patient. So that was all about beta blocker and calcium channel blocker toxicity. And before we close this session, I will just spend a few minutes about a condition that is very closely related to these two overdoses, but it's not actually an overdose. So this is another case, elderly gentleman, 64-year-old gentleman coming with a history of diabetes, hypertension, heart failure with reduced ejection fraction, coming with a few days of nausea, vomiting, diarrhea, and decreased urine output. And this medication list includes an ACE inhibitor and a beta blocker. So you again, as always, you do a primary survey and you find out the patient is again bradycardic and hypotensive. So you get an ECG, and ECG here is basically significant for bradycardia. So there is significant bradycardia here, and the patient's potassium comes back at 6.5. So this combination of findings, the the bradycardia, the hypertension, the hypokalemia, the hyperkalemia, I'm sorry, and the as well as the use of an ACE inhibitor and as well as the use of a beta blocker, all of them points and as well as a decreased urine output, all of this points to a diagnosis of BRASH syndrome. So BRASH syndrome is basically a combination of bradycardia, renal failure, which can be either acute or acute and chronic, AV nodal blocker toxicity, shock, and hyperkalemia. So what exactly is BRASH? So BRASH is basically a condition that has been identified, recognized more in the recent years because a lot of patients are now on these medications, calcium channel blockers, beta blockers, etc. So as well as things like ACE inhibitors. So what are the problems with ACE inhibitors? ACE inhibitors can lead to hyperkalemia. So basically the problem with this is that we have a combination of hyperkalemia and something that is triggering renal failure. So, like in that particular gentleman, patient was having gastroenteritis, some kind of pre-renal AKI happened, and then everything happens synergistically. So then the some renally clear beta blockers can accumulate, and some beta blockers can also worsen hyperkalemia. Then hyperkalemia can by itself can also lead to bradycardia, and the bradycardia will again lead to decreased perfusion to the kidneys. Then also again worsen the renal failure. So this is a whole vicious cycle basically. So this is basically a continuum. You have BRASH syndrome in the middle, and you have on the side you have pure hyperkalemia related effects, and you have on one another side you have pure AV nodal overdoses. So how do you actually differentiate this? So BRASH has a simple hyperkalemia. Usually, if the patient having bradycardia because of hyperkalemia, generally they have patient potassium to be more than 7. Whereas in BRASH syndrome, we will have bradycardia with milder elevations of potassium. So that is one clue where you should be actually suspecting this hyperkalemia. Similarly, you will have ECG findings where you will have only bradycardia without that much other findings suggestive of severe hyperkalemia. That is again another situation where you start suspecting that the patient is having BRASH syndrome. So what about BRASH syndrome versus AV nodal blocker overdose? BRASH syndrome is basically patient is actually taking an appropriate amount of AV nodal blocker as prescribed by the clinician. Whereas in AV nodal blocker overdose, the patient deliberately actually overdose themselves. But in BRASH syndrome, patient is taking the medication appropriately, but due to problems like renal failure and other things, it actually started having a deleterious effect on the body. So what is the trigger for that? Basically, most of the causes of AKI, mostly it's going to be some kind of pre-renal AKI like gastroenteritis, but you can have other renal causes of AKI as well, like acute glomerulonephritis, etc. And post-renal causes are also possible. So you have to look for those things. Any causes of hyperkalemia, like any medication like potassium sparing diuretics, ACE inhibitors, they can obviously make things worse. And recent dose escalation of your AV nodal blocker or recent introduction of a AV nodal blocker that can also make things worse. So how do you actually manage this condition? There are 4 pillars of the management. One is volume management. Second is treatment of the bradycardia. Third is the treatment of the hyperkalemia. And fourth is obviously the treatment of any underlying. So volume management is important because this is where you have to get your focus into play. You can also get help from history and physical, but as we all know, history and physical are not very reliable for determining volume status compared to your focus. So you have to determine if the patient is hypovolemic or hypervolemic. And if the patient is hypovolemic, generally, of course, we'll have to start giving IV fluids. If the patient is acidotic as well, then you can consider giving something like acidotic bicarb solution as well. If the patient is fluid order, perhaps the patient is having the AKI that has been going on for a few days before the patient actually showed up to the hospital, maybe the patient is actually fluid overload. In that case, you might actually can consider doing some diuretics for the patient. Bradycardia management here, this is another case where you probably better off going straight away with something like calcium instead of your atropine, because anyways hyperkalemia is one of the main causes of the bradycardia. So Uh, IV calcium is a big thing in bradycardia management, especially if the patient is peri-RS tender. You can give other things like ADR or isoprene infusion also, as well to counter the bradycardia. Sometimes the patient, even if the patient is having bradycardia, sometimes the patient's BP might be normal, but they will be having other signs of malperfusion, like cold extremities, decreased urine output, etc. So those patients are also unstable. So despite the normal BP readings, those patients are also going to be needing treatment. So those cases you can consider things like isoprene as well. Hyperkalemia management is basically basic hyperkalemia, the one that we all know and we all do every day. So basically, calcium gluconate, insulin dextrose, and salbutamol, all of those things. And if it's not responding to that, you'll have to go for other things as well, like potassium binding soda bicarbonate, diuretics, and lastly dialysis, of course. So the pitfalls is in BRASH syndrome, we should definitely, if your patient is requiring fluids, go for something like ringer lactate or plasmid. Avoid normal saline because that is basically a hyper, sorry, that is a nice acidotic fluid and probably it won't be a best option for this scenario because most of these patients will have some kind of uremic acidosis most of the time. And so also we have to be careful about patients having signs of malperfusion, even the patient having normal blood pressure. So if you have bradycardia and patient of malperfusion, those patients are also require treatment. So don't ignore those patients as well. So that was the end of the session. And if you have any doubts, then you can ask them right now.